This is Dr. Bess Miller, and I'm here with Mr. Gary West. Today's date is February 28, 2018, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I'm interviewing Mr. West as part of the oral history project, The Early Years of AIDS, CDC's Response to a Historic Epidemic. We're here to discuss your experience during the early years of CDC's work on what would become known as AIDS. Mr. West, do I have your permission to interview you and to record this interview?
Yes, you do.
Gary, you've had an outstanding career in public health, providing leadership in program development, implementation and evaluation, operations research, and teaching. At CDC for over 30 years, at the NGO FHI 360, and in additional capacities. Your work spanned a number of programs, including HIV, STDs, immunizations, and reproductive health. You were one of the earliest leaders in developing HIV prevention programs and HIV counseling and testing centers across the U.S. before there were proven interventions or treatment. You provided leadership in engaging communities in the U.S. to address HIV/AIDS and in encouraging leadership of people living with HIV/AIDS to support programs. And you went on to provide leadership in developing countries and implementing HIV/AIDS programs globally, with a special focus on Vietnam. In addition to your programmatic work, you held a number of leadership positions at CDC, including Deputy Director of the Division of HIV/AIDS and Deputy Director for CDC's Global AIDS Program, which later became the CDC operation that implemented PEPFAR, the President's Emergency Plan for AIDS Relief. We have a lot to discuss. But let's begin with your background.
Sure.
Would you tell me about where you grew up and your early family life? Any role models for health or medicine?
Well, my family was from Montana. They were a pioneer family, and they moved to Seattle, and I was actually born in Seattle and grew up there. My father was an engineer in Seattle during the Second World War, and I lived a pretty, uneventful early years, I think. I graduated from Shoreline High School, and then at age 17, the Vietnam War was underway, so I was going to be drafted, and so I joined the Air Force and served 4 years in the military, including going to Vietnam and serving in a Tactical Air Command fighter squadron during that time. I went to school while I was in the Air Force, but then when I was there, I realized that you need to go to college. So no one in my family had ever been to college, so they really knew nothing about it. And there was really no one there to guide me. But I knew I needed to do that. My grandmother had been to in Utah, had been to a teacher's school in Logan, Utah. And she was the daughter of a Mormon family, a polygamous Mormon family. And when she came back, her and her sister, they tried to marry her off to an older person who already had other wives. So she escaped and went up to Flathead Lake in western Montana and became the teacher at the Indian school. And when I was a little boy, she was there in our house, and she taught me how to read. And so if there's a role model, it's her. I still remember her combing her long hair and her penetrating eyes, and I always thought of her. But she was the first person in our family ever to go to college. And so, but after the Air Force, I felt I needed to go, and I turned out I was a very good student. And I decided to focus on one of the careers that is certainly never going to yield any money for you in your whole life, and that was primatology. I wanted to be a monkey doctor. And so I studied, got my bachelor's degree, and then I went into graduate school to study medical anthropology and ran out of money and had to quit. So at that time, Seattle was going through one of its many recessions with Boeing, and so they were saying the last person to leave Seattle turned the lights out. So I flew as far away from Atlanta as I could, thinking there might be a job there, and I went to Yerkes Institute at Emory and applied for a job to work in their primate center, and they told me that there were no jobs and wouldn't be any jobs in the primate center for years. But they said, go to CDC. they have primate colony. So I went over to CDC, and I went to the HR department and applied for the primate center, and they told me they had 2 positions. They didn't expect to have a vacancy for 10 or 20 years, but had I thought about working with humans. And so I went back and rewrote my CV, and they said there was a man upstairs that you should go talk to, and I talked to him, and he made an appointment, and they hired me based on my human qualifications. So that's how I got to CDC, which was kind of serendipitous, I think.
Very serendipitous.
And and then I went on in later years to get several master's degrees. And while I was with CDC, even though I was not a physician, I was accepted into the EIS program so I went through the training, and then the state epidemiologist in Utah was my mentor, and I worked about 2-3 years as an epidemiologist and also as the director of the immunization program in Utah. So I was one of the very first to be admitted, even though I wasn't technically full admittance, but I went through the training and learned a lot.
So you were in Utah initially, and then you had some other state assignments.
Well, actually, I started in Chicago, and I worked on syphilis, which was kind of a training ground for the new CDC staff at that time, which was really interesting to learn basic epidemiology. And later on, when HIV hit, there was a lot of analogs there.
Was that the Public Health Advisor
That was
series?
the Public Health Advisor series. That was really the only way at that time that you could come in without an MD or a PhD.
Can you
really,
tell us a
almost
little
no
bit
PhDs.
more about the role of the Public Health Advisor, which was so important? And
Sure.
what did you do in Chicago?
Well, the public health advisor is kind of a cross between a manager and epidemiologist. That's why I think of it. It's kind of part program and part science. It's more of implementation science, although kind of an early version of it, I think. And when I was in Chicago, I was really learning epidemiology. It was basically casework, almost exclusively syphilis. There were many, many syphilis cases. It's hard to think now there could be. I remember talking to 12 patients myself in one day in our clinic there in Chicago. And so you learned a lot about the kind of fundamentals of epidemiology, of how to interview, how to follow up patients, how to talk to people who've been exposed to them, how to bring them into the treatment and understand the details about treatment. So it was really quite a great proving ground. But I didn't get a lot of managerial experience there. But then I moved to, I did go and work on drug control. Then I was assigned to the FDA group that was going to license methadone, and I worked on that team while I was there. So I did get some other experiences that proved useful later in my career.
And how did your role as a CDC assignee interdigitate with the state and local health department?
Well, not very well, actually. Because the CDC staff, there were many CDC advisors, maybe 20, that were there in Chicago. It was a huge program. But the clinic was run by the local staff. And there was my supervisor there always stressed to us how important it is to be polite and supportive of the local people. We're here as their guest and all this stuff. So he was very good. And we tried hard to do that. But there was a tension to have, and we were kind of better paid, not as diverse. And just kind of who are these people was in the background there. But I worked hard to kind of get their trust, and I think to some degree I got it. But I moved later to Pennsylvania, and I became the manager for the STD control program for the 1/3 of the state. And there was just one CDC public health advisor, and everyone's local. And there was a lot better relationship. They were much more receptive. They appreciated the technical knowledge that even although I'd been a short time with CDC, I really had amassed quite a bit. And also the ties back to CDC Atlanta were important. So that was a pretty positive and supportive relationship. And I think I was able to contribute, but I learned a lot from them as well. So that was a pretty good exchange. And that's the way it was most of the time in the States.
Before we move on to
Sure.
you're beginning to work on AIDS issues, you were involved in the smallpox eradication program in Bangladesh. How did you get involved with that? That was, 1975?
That's right. Well, they needed people. I heard about it. I volunteered, and they took me, and I went to Bangladesh. And
Who were some of the other colleagues or leads?
Pat McConnell, D.A. Henderson visited us there.
Yeah.
Bill Fagey was not there at the time. He was in India, and he was there years before me. And
Peter Drotman, was Peter in
I think Peter was, but I didn't know Peter then.
Okay.
And most of the people around me, I was supervised by a Russian,
Okay.
Dr. Slava Silivanov. Was my Russian advisor, and the other epidemiologists in my area were Egyptian. So I got to be really close with them and learned how to drink vodka with Slava and play chess, although I beat him once, which was humiliating to him that an American could beat him in chess. But it was only once.
So how long were you in Bangladesh?
I was here about 4 months, I think it was. And during that time, I lost about 25% of my body weight, and I had less body weight then than I have today. So it was a little bit arduous. And I think there's a lot of stories about this, but I think for me, the last person, I believe it's the last person to die of smallpox, the wild variola major, was my patient in Bangladesh in '75, a 12-year-old boy they had hid him from us, thinking that we would shoot him if we found him. There was a misunderstanding there. So he died, but that was the last death, not the last case, but that was the last death in Bangladesh.
Wow.
But it was a thrill to work there, to be there at the end of a disease. I just can't tell you how thrilling that was, and to be searching for the disease everywhere we could go. I'd walk many kilometers every day going to different villages, trying to find new cases of smallpox, and we couldn't find them. And it started to dawn on me that maybe this is the end. And they just had a terrible epidemic just the year before, and to go from that really high level, and Pat McConnell was the person that had been the advisor ahead of me, so he'd done a lot of really great work, and so had the others that were there. And so I was really working with the remnants of that large epidemic. But I remember when I first got there, and I had to sleep outside, no mosquito net. I must have been bit 1,000 times that night. We went across the Brahmaputra River, little sailboat, and went to see a baby who had smallpox. And the baby, it was such a horrifying thing to see it. The baby's covered in lesions and screaming every time it took a breath. And you really kind of see the presence of this disease. I think now we have no appreciation for what the world went through when smallpox was rampant. But that was a life-changing moment for me. I mean, I was committed, but I was really committed after that. And to be having such an exhilarating success. So I went back to the U.S. and worked on measles elimination, and Bill Fagey, was a push that, and so did many others, and we made some progress on that as well.
So, beginning to look at your work on HIV/AIDS, in the early 80s, I guess 83, you were assigned to the state of California.
That's right.
As director of immunizations.
That's right.
And CDC contacted you to look at an assessment of HIV/AIDS prevention activities in California.
Right.
Do you remember that?
Oh, yeah.
What were some of the things you were doing then, just in still relatively early times?
Well, yeah, they thought about me because Ward Cates had worked with me in Thailand back in 1980. And so he remembered me from that. And Jack Kirby, who had become the senior public health advisor for the National Immunization Program, remembered me as well. And so they contacted me in, I think it was late 83 or early 84. No, I'm sorry, in early 85 to see if I would come and join and work on HIV/AIDS, especially on the prevention side that was just going to start. But they said before I go, they wanted me to do an assessment of what was actually going on in California. So I went around and talked to all the organizations that I could find that were working on AIDS, and there were many in California already, and asked about the work they were doing and what needed to be done and what their needs were. And I remembered talking to the health departments in San Francisco and Los Angeles about the programs. They were just starting, the test had just been licensed that year. And so they were starting to start up the alternate test sites, alternative to going to the blood bank to learn your status. And how that was working, it was just really brand new at that point, and how it could work over time. Already the thoughts were coming in my mind about how a counseling and testing program for prevention could actually be designed. And I went down and talked to a lot of the organizations that were supporting people living with AIDS. And I remember Project Angel Food, which was feeding people living with AIDS. And I remember that they had the cast of Frasier, the TV show, delivering food to the people. I liked that show, and I was so impressed. They were out there, doing things, and so were many others. And I remember going to a group that was formed by a group of lesbians, and they were also providing care. And so I learned a lot about the program in California at that time, which was just beginning. But I could sense the community mobilization that was going really spontaneous. There was no one really directing this. This was just happening because of in response to the AIDS epidemic. Elizabeth Taylor had taken a big interest in all this, and she had started stuff, and I had a friend who was a friend of hers, and I'd heard a lot about what they were doing. So I got a good background of the epidemiology, the program capacities, the role of NGOs, things they could do. But I could also tell that they didn't really have a program in the sense that they were kind of holding the tide. They weren't able to really stem anything in terms of the spread of HIV, or really almost palliative care for people with AIDS is what they were doing. And there was an enormous number of deaths during that time. And like the health department in San Francisco lost a really lot of employees, and there were funerals all the time, and it was quite a. And there's still a lot of speculation about how HIV is and is not transmitted. That was kind of glumming up the communication networks. So it was a good experience. And then I went back with that to Atlanta.
When you got to Atlanta in the SCD operations branch, you were starting out to serve as project officer for some AIDS risk reduction projects.
That's right.
Which involved various AIDS NGOs like the Gay Men's Health Crisis and others. Can you tell us a little bit about that, the early AIDS risk reduction? Well,
I had, I think it was 13 projects, and they was called the HIV/AIDS Innovative Risk Reduction Projects. And some of them were absolute research, and others were kind of program models that they were trying to design. But they were most of them were involved in intervention design. And I had, in my college training, I had studied a lot of this stuff, so.
When you were reassigned to Atlanta in the STD operations branch to serve as the project officer, you were one of the early persons working on these risk reduction grants. Can you tell us a little bit about what those were and how you worked with them? So
there were 13 projects, and I was their project officer, so I was supposed to, help them manage their project, meet all the grant requirements, and also, when I could, provide technical advice or connect them to someone who could provide it if I couldn't. And there were 13, so that included the Gay Men's Health Crisis in New York City, Sloan Kettering, Beth Israel, AIDS Project LA, the Ohio State Health Department, the National Conference of State Legislators, the United States Conference of Mayors, and I'm forgetting some, I'm sure there. But they were really quite a mix of projects, all kind of focused in the area of prevention. And so I started off this by visiting each of the projects, trying to understand what they were actually doing, read over their application. They had already been funded before I came.
And what were they doing? What were some of
They were doing intervention design. In other words, most of them were working or focused on gay men at that point. And they were trying to have behavioral interventions that would reduce their risks of acquiring HIV. And so,
for example,
there were very common models. One was to do a counseling of some type, individual or group. Actually, these were all individual behavioral interventions. The ones that were doing that were all focused on the individual. There were no group ones in this group. And so they would devise an intervention, have a control group, and see if they could show some risk reduction occurring in the experimental group. And another one, gay men.
And the risks might be unprotected sex?
The risk would be unprotected sex, multiple partners. That was basically it.
Okay.
One of the problems was that we had no way to measure these changes in behavior. First of all, it was all self-report. So we know that even I knew back in those days that self-report you have to take with a grain of salt. It may or may not be true. And there's social desirability bias, that when they're talking to an interviewer, they know the interviewer wants you to cut down your number of sexual partners. You're very likely to try to please the interviewer. So this is just common in all this research. So these studies all had this problem. So they had no real good way to measure the behavior, and they couldn't measure the outcomes either. They couldn't measure the reduction in sexually transmitted infections. They couldn't see anything about HIV incidence. So these are really, in my mind, these are wonderful people working on this, good scientists, but the state of technology was not that high at that moment. And they were kind of the first version of these projects, which would evolve over time and get a lot better, although they were always limited in their impact. So, and a couple of the projects were kind of lost. They didn't really know what to do. They didn't really know how they got the money. Because at that time, they were trying to get the money out to get things started, and they were probably a little bit more permissive than they would have been later, and they became, over time, much more strict. There was another group of projects that Kevin O'Reilly was coordinating. He was an anthropologist. He had social anthropology, cultural anthropology in his forte, and it was called the Community Demonstration Projects. And there they were trying to see if they could move communities to safer sex. And I think actually there was more science there, a better chance to show a difference. Although I'm not sure that they were able to prove in that group, but they did kind of inspire the future. So during this time, the gay men's health crisis, they were a wonderful organization and still are. When I went up there, I couldn't believe that we had funded the gay men's health crisis. I was so thrilled that they had seen this community threatened so much by AIDS that the CDC, the kind of leader, heroic organization that it is, would fund them to help the community out as best it could, and they'd send me up to help them as much as I could. I was thrilled. So I went up there. They welcomed me, and they were really friendly to me, and they showed me some pamphlets that they had developed, which were quite explicit, and then they showed me a video that they had used the CDC funds. They'd not used the CDC funds for the pamphlet, but they had used the CDC funds for the video, which was basically how to help gay men become monogamous. Meet people, become monogamous, and not have multiple partners, which we can see in the data that was a big risk for the gay men. The more partners, the more likelihood of HIV. So I went up there, and I thought that the video, didn't think it would be very effective, but I thought it was something that should be pioneered. I brought the video back to CDC to show to Dr. Ward Cates, did he know that they had developed this video? And he wasn't that interested in it, to be honest with you, and he didn't look at the video. About 2 months later, Senator Jesse Helms in North Carolina got a hold of the pamphlets and the video, and then he took those to President Ronald Reagan, who didn't like them. And they called down to CDC, and they wanted to know who the project officer was, and they called Dr. Mason and Walt Dowdle, who was the deputy director of CDC at that time, and they had a vote in the Senate to kind of censure CDC 97-0 over this project, which was, I was out traveling this time, and they were scrambling to try and find the video to see what Ward had done with the video, but they couldn't find the video. And so that became quite an interesting experience. And but to CDC's credit, it stood up as best it could, which was pretty hard with the president against you, and we didn't defund them. And although later Congress demanded we defund them, so they got defunded by Congress, not by us. And they tried to support the gay organization in every way they could, if they were going to work on scientific interventions to,
so you
save lives.
Did you have to testify?
I testified several times, and I testified a lot to Dr. Mason about what happened. Dr. Dowdle, who was my big supporter in this, because I had actually had nothing to do with the development of the video. I mean, I saw nothing wrong with the video, but I was not involved. I just went up and found that it hadn't been developed. But he explained to many congressmen and what had happened, and they had a big chart showing when Gary came to Atlanta, which was after the video was actually developed, because they really wanted to punish a CDC staff person, but they weren't able to find anything that punished me for. I thought, this is the AIDS epidemic. We're supposed to be helping people. This is like kind of an unnecessary sideshow here.
How did you respond emotionally to all of this? Were you Were you rattled significantly? Were you sort of calm? What was your approach then?
Well, I learned that to explain social learning theory, you have to be able to do it to someone that's screaming at you and on the other side. I learned that. I told a lot of the behavioral scientists later on that they're just not going to accept this stuff. But first, I was not rattled at all because I had done nothing. I mean, I didn't think I was guilty of any crime or any ethical violation. But later on, when so many congressmen and so much public attention came to this, I had a few moments of fear, but I always felt that CDC would not make would not do anything to me personally because they knew I had never done anything wrong. And they didn't. They stood up. They had a lot of difficult meetings over this, but they always protected me. So I was quite grateful, especially to Dr. Dowdle, who was the one who had to endure the most harassment over that. But we have to do this work. We have to go out there and do the research and and see whether we can find something that lowers risk. And at the end, I had to testify at the National AIDS Commission. They had an admiral, I think, who was in charge of the AIDS Commission at that time. And so I went in and testified to them, and then I told them during the thing that if it hadn't been for the shower scene, I thought we would have been just fine. They all broke into laughter, and that was the end of the. Actually, they showed it in bars, and most gay men found it quite boring. We found out later on that the more explicit, the more effective the communication. It might upset a person who's not intended for, and maybe it should or should not be funded with federal funds. The Helms Amendment came through and was told we could not promote homosexuality, and so we had to think how to cross, walk that line. But we learned later that the more explicit, the better it they understand better what it is that you're trying to tell them. Whether they really worked to reduce risk in a substantial way, it was never proven, as far as I know.
So moving on, in early '87, there was a proposal for HIV/AIDS counseling and testing project, and they had continued to move you up the corporate ladder, so you were at the National Center for Prevention Services.
Right.
And just to set the stage, in '86, there were 32,000 cases. In '87, 47,000 AIDS cases, and surveillance for AIDS cases changed in '87.
Right.
But there were 17,000 deaths, and WHO by that time was estimating that 5 to 10 million persons were infected.
Right.
So we're at a point in the epidemic where it's exponentially rising.
Right.
There still isn't a real treatment, although in '87 FDA first approved zidovudine.
Right.
But it was not yet
No.
scaled up at all. In fact, in '87, the AIDS Coalition to Unleash Power, ACT UP, was formed in New York. So a lot of community response and anger.
That's right.
So here's where, and you've already said, you're in the middle of the Reagan administration.
Right.
So here's where you're involved with a lead role in setting basically the goals and objectives of this implementation plan for national HIV counseling and testing.
Right.
Can you tell us a little bit about this, the beginning of it, what your role was, what were the goals, and how it worked out?
Yes, well, I was trying to remember exactly how this got started, but I was somehow stimulated to write a plan for an HIV counseling and testing program that would have prevention as its main focus, because there was no outlet to treatment. There was no way no treatment to move the patients into. And we knew that there was many people wanted to know their HIV status, and there was definitely a good public health need for them to know that and possibly take precautions to not spread it to someone else and avail themselves of whatever support there might be for someone living with AIDS at that time. So all I remember, and this is actually before I moved into the National Center for Prevention Services, I was still working with Jack Kirby. And I had been sending Jack Kirby memos about things we should be doing, and he had a folder in his office about 50 memos from me, which I don't think Ward Cates ever saw. But one
So
was...
Jack Kirby, is he the branch chief, and Ward Cates the division director of the
Yeah, he was,
division?
that's right. And so I don't think they really knew what to do with all these crazy ideas that I had. But one was that we need to have a counseling and testing program. And so I sat down at my computer one day and I wrote out a program. And I tried to think about what the goals and objectives would actually be. And it was focused on people learning their status and being referred to whatever source of service they might need and would be available. And
What might that be? There was nothing much to offer.
well, there could be TB treatment. That was one. There was some counseling available. There was some housing and food support in some of the places. There were things kind of spontaneously becoming available. So there wasn't nothing. There wasn't enough, but there were things. And so one of the ideas of the counseling and testing program would actually know what's available. And so I came up with this idea of a terrible acronym, CTRPN, which was counseling, testing, referral, and partner notification. So all of these were very controversial at the time. Now, except maybe the testing wasn't so controversial, but at that time we had to give people basic information about HIV. We had to warn them about confidentiality because there was a lot of discrimination. Terrible things could happen to you, and did happen to a few people who disclosed their status, their positive status to others. Many family members, I would have gay men call me up in the office and tell me that family had thrown them out of the house because they told they were gay and positive. So there's a lot of really heartbreak going on, breaking up of families, and so there needed to be counseling on prevention. So the CT was not so hard to justify. And when everyone got that, later it became complicated because it was thought to be too long. Then the referral was initially to just find the resources that might be available in that community and help them get into those services if that's at all possible. And then the partner notification, which itself was very controversial at that time, and still is. If you go out around the world today, a lot of programs don't do it. And I think that's a big threat to women, and not just women, but in particular women, because women are less likely to know their risks than men do, and they're at risk, and they don't find out until their male partner dies or something. So part notification was the other part. And I was trying to say this is one program. The other thought was that this is going to be managed at the state and local level, and we were going to give grants, eventually to state and local jurisdictions to carry this out. So it had to be something that was feasible and useful to them. And it couldn't be too complicated and too expensive. So I tried to keep all those things in mind and wrote an outline for a program that would meet those, I thought at that time, would meet those requirements.
Let me ask you, so you had seen in California and elsewhere the beginnings of testing. You mentioned the alternative testing sites in California. Were those anonymous, or were those in a situation where the person tested was made aware of their... So in other words, there was a change taking place in terms of how to get the results to the patient but preserve confidentiality.
Right, so those first sites were anonymous. They were basically, at least all the ones I knew about, they were basically a way for a person to thought they might be at risk to learn their status confidentially and not have to disclose anything in any kind of record that might harm their life or family in any way. That was the first iteration of it. And it was to take the pressure off the blood banks because, there could be a number of people in the window period. The positive blood would be thrown out, but if they're in the window period, which was weeks long or months long at that time, that blood could go into the pool and be transfused or something, and go into a blood product later on and infect people. So they had to stop that. So the first goal was that. But now we think about a program. So there was so much discrimination and so much concern about losing confidentiality, we felt we needed to keep an anonymous option, a place where people could go.
Give a number.
Give a number.
Get the number.
There was different ways of doing it. Usually it was a number of some type, but these are run by usually local health departments. And there were innovative ways to keep it anonymous. But we felt that it was an essential element because we would not reach a very large portion of people at risk if we didn't have this. And then we started up the confidential sites, which would be maybe, some of them were dedicated confidential sites, just come in, you give your name, and it's kept confidential, strictly confidential, but it's not anonymous. But some of the STD clinics were confidential test sites. They would check you for STDs, but also they can do HIV testing. And we started having a number of sites like that, either dedicated or maybe part of another service. By the way, people were going in all the time, though, and getting tested, sometimes without them knowing it, in hospitals. It was a big scare about nosocomial infection in hospitals that spreading to the medical staff, especially surgeons. And CDC put out the healthcare guidelines for HIV a few years after that. So we had to take all of this into account and think about a program that could be managed effectively and serve millions of people, across the country. And so the first draft pretty much went into implementation. And then over time, we made it better. One of the things we had that was very important was a data system in this, and we wanted to be able to know as much about. We thought of the counseling and testing as it's not a surveillance program, but it can contribute to knowledge about trends and issues in HIV. And so we set up two parts. One was just a summary report that the jurisdictions would make of the number of people tested positive and so forth. And another one was a client-level database where they would send not the names but the data to CDC, and we could do more sophisticated analyses of the risks and so forth.
How was this accepted by various communities? And in terms of the risk groups, are we still talking initially mostly about the gay men risk groups, or are we moving into, by 87, various diseases that IV drug users were included in the AIDS case definition, so you had a big change in the profile. You had more IV drug users, more minorities, and so on. What was the uptake of this program like in the communities for counseling and testing? And I still am not getting a clear sense of what's in it for me. You can't treat me. I'm going to die in 6 months. I don't want to bother with this. How did that work?
Well, in the first year or so, the uptake was huge because there was a pent-up demand for learning your status. And so we knew about the risks of drug users because that had been actually documented in New York City and other places, with pneumocystis pneumonia and everything, pretty well. So we, at the start, considered for sure, at a minimum, we needed people who had men who have sex with men. We came up with that term in my office one night. And people who were injected drugs and partners of people living with HIV were the first ones that we put into it. Now, CDC added Haitians to that at one point, which Dr. Harold Jaffe can tell you was a mistake, and they dropped that later on. But we were already seen very early on in minority communities, especially African American communities, a higher rate than we were seeing in other populations. That was quickly visible. But we saw a lot of African Americans, but there was definitely resistance to it. So in the first phase, there was resistance to the minority communities about the stigmatization of minorities being associated with AIDS was almost from the start was a big issue. And I went to many meetings talking about how that this was something we need to be very careful about because it's real. But the truth is there's many, especially African Americans, that need to get counseling and testing because we know that the risk is higher in that population, the prevalence is higher, and the incidence is probably also higher. So, but there was a lot of not so sure we accept this. I remember I went to Harvard, and the Harvard, black students of Harvard, that's the group they call themselves, came to talk to me about how we were stigmatizing all the African American populations through our work at CDC. So I tried to explain to them the background. The gay community was concerned about confidentiality and discrimination, and many people came in, but a lot of others, as soon as the test was they found ways to get the test sometimes other than ours. There was other institutions out there pretty soon thereafter that could also provide the test. Had got some arrangement to get the test kits.
So the HIV counseling and testing projects were implemented in a subset of state and local health departments initially. How did that money go out, and were you?
Well, they were basically every state.
Every state.
So this, you have to remember what we're doing here. This is a national program, and we knew at the start. And the money went out through cooperative agreements with CDC, and I wrote the announcement for this and gave some of the first guidance on how to structure these sites, where to place them, and so forth. And they were pretty good at following this, at following our recommendations. And we already have the CDC counseling and testing guidelines for the actual test, how the test is performed, and basic information about how to administer the test.
So this was the ELISA test at that time?
This was the ELISA test, yeah. And they had the Western blot for the confirmation.
Okay.
And
can you tell us a little bit about the counseling? Now that ended up being, over time, kind of a big controversy. But
yeah.
Tell us a little bit about the type of counseling that was used at this point. And again, here we don't have treatment yet.
No.
So we're...
And we need to talk about that issue. But
yeah.
The counseling at the start was basically very didactic. It was like, here's the facts about AIDS. What's your... More like we interviewed the syphilis patients. And here's what you need to do next in terms of, informing others or not informing others, getting services, and so forth. We didn't have a lot to offer.
How long did it take? And what type of person could do the counseling?
Well, these were unknown things at the time. At that time, the counseling was probably, for a negative person, was probably 30 minutes or something like that. And a lot of it was about, facts about the disease and so forth. And then if they were positive, if they came back, usually about 2 weeks later, we didn't have a rapid test. Mm-hmm. They had to come back about 2 weeks later. We lost many people in that. And then it would be more extensive counseling about, and we had a whole protocol about people who were found to be infected and what to go over with them and how to protect, spreading others, what resources they might be able to avail themselves of, and so forth. And that would be an hour or maybe more. Some of these patients had a lot of issues,
And the training for the counselors, what was that like?
The training was, they didn't have it at the start. There was a brief that when the alternate test site started, they had a training program. They had a brief training for counselors to work in the alternate test sites. So that was the one we used initially. But I have a background in social science, and Dr. Ron Valdesari, who was my colleague for a lot of this, first was Steve Bowen, Dr. Steve Bowen, and then Dr. Ron Valdesari. We chaired a meeting looking at the counseling model and came up with this client-centered counseling model, which is basically Rogerian psychology, which I had studied as a student, some years before. Ron's a pathologist, but he did some research. But it's basically personality, based on the theories of personality. And so we got a group of experts around, and we came up with this protocol, and it was a good protocol. It was later, through a Project Respect, a randomized controlled trial of STD patients, and found that in people who were negative, didn't have HIV, that the counseling model would reduce their return for STDs and would increase condom use. Now, some of the epidemiologists at CDC don't believe the results of this, but it's actually pretty firm. And it was adopted by WHO, and it's...
So the essence of, what is the essence then of that approach to counseling?
In other words, that I know your background, your risk profile, and I counsel on your issues.
Okay.
You see, I don't just give you facts, spur facts. I don't lecture you. I try to
so
find out.
I get to know you.
I try to get to know you and know your risks. Now, the American Psychoanalytic Association was totally against this, because they said you cannot teach someone to be a counselor through. We had it was a 2-week training course. My wife taught it, actually. You can't become a counselor in 2 weeks. That was their idea. I think they're actually wrong. They were wrong on that one. You can be a focused counselor, a targeted counselor. It's what these people, they're not going to counsel you on your drug use and on your domestic abuse or stuff like this or marriage, but they can help you in this well-defined area. And so I think it actually turned the tide. It took a while. It was initially resisted. People didn't, we just tell people what to do, just give them the facts. But I told him and Ron told them, if you focus on their needs, you're much more likely to have a good outcome than if you don't. Just think about it. If you're the patient, think about it. And the other models that were out there were like multi-session counseling models, kind of a Freudian type of model that probably won't work, in my opinion. Even Freudian psychotherapy doesn't have a lot of evidence behind it. And we could never afford it. We can barely get the patients to come back for their test results. We're not going to get them to come back for 10 sessions psychoanalytic counseling. It's just not going to work. This is really the most we can implement in the public sector.
So how did it play out then? Was there additional training for counselors to?
That's when we got the 2-week course.
Or what?
Well, we had the 2 weeks, and then the idea was that they would be supported by counselors in the clinic who'd already been trained and had experience. And, you implement something across the whole country, you're going to get differences in implementation. And we carried out an assessment of this a few years later and found out that it had not penetrated very well into the sites. That most of them were still doing the didactic approach. Now, later on, when CDC started realizing that we're never going to get all the people who are HIV infected into the counseling and testing sites, because they were looking at the AIDS patients coming in and seeing that their CD4 counts, their immune systems, maybe like 80% of the people coming in, something like that, their immune system was already destroyed before they entered treatment. This was later on when treatment came.
Yeah.
So they were coming in late. So we're missing many people and serving other people late. So the approach to do this, it needs to be done, but it's only going to reach maybe 30% of the total population needs to be reached or something like that. We don't have a clear idea. So they wanted to move into the more targeted counseling and health facilities where people at risk were coming, or where there might be a more generalized epidemic like in some parts of New York City. We actually knew early on that this was the case, and we wanted to get hospitals to implement these programs, but we had a lot of trouble getting them to do that.
So once there was treatment offered, this scenario changes. But while there wasn't, what did these counseling and testing sites have to offer those who came in? I'm still...
Well, they didn't have that much to offer. Let's be straightforward. You could learn your status, which is not insignificant. But
maybe a death sentence, essentially.
Well, it was called the cruel hoax. I don't know if you heard about this, but the idea that we test someone and they would find out that they're positive, there's nothing we can do for them really. And so they're going to get AIDS and they're going to die. And, it's really hard to kind of hide that fact. Now, they might live 5-10 years until that happened, and maybe by that time we would have treatments. But even then, many of them coming in, we weren't doing their viral loads or we weren't doing their CD4s at the time, but many of them were actually late stage already. So one very prominent physician from Michigan, a wonderful person, but she and I disagreed on this, that this was a cruel hoax, that why tell them? And I think this is a kind of an ethical question that comes out in all kinds of healthcare and probably other areas. Should a person who is living with a fatal disease should it be okay for them to learn that? Well, this is voluntary testing. So at that time, we were not mandating. We wanted them to be tested. We wanted to encourage them. We thought the benefits outweighed the risk, but the benefits weren't that great.
Okay.
But they had the right to know.
So looking back on it, are you pleased with that earliest effort, and were there things you would have done differently, or do you think it was something pretty good on the path that fortunately there were drugs being developed?
Well, I have two minds of this. I mean, I think that this was a pretty good start considering what we knew, which was not that much. And, you had to start somewhere. You couldn't just like, CDC couldn't just like go into a fetal position and say, we're not going to address this. And by the way, that was an issue at the time. Not so much for CDC, but for most of the rest of the world, it was an issue. The state health departments in particular, which I should talk about. But we had to do something, and this is you have to come up with the best you can do at this moment in time, given the knowledge and the tools you have available. Now, looking back now, I have a much clearer picture of how to address a lot of these things. And the programs still haven't caught up to where I think they should be. I published a couple papers on this that talk about strategies that I think could work a lot better than what we're doing even today. Especially now that we have more tools, like we have this fantastic treatment. And I was, the study that showed that treatment is prevention was done by FHI with University of North Carolina. I was the manager over that. I was the senior vice president when that study was being carried out at FHI. So, and we tried, actually early on, we tried to prove that lowering viral load would have some impact on transmission. And Melinda Moore worked in I don't remember Melinda Moore, she worked in our office then, and she did this extensive literature review, but came back at the end of it and said, we can't prove it. I mean, we don't have a drug, we just had the AZT at that time. And no one thought the AZT is going to have a lot of impact on this. So it wasn't until Dr. Ho, with his discoveries, and we got combination antiretroviral therapy, and even then we didn't know about the prevention part. It wasn't until just a few years ago that we were able to prove without question that it does actually greatly lower the risks of transmission.
Tell us about the states you mentioned.
Yeah,
states varied in their response.
Well, CDC was shocked that all of a sudden, Jim Curran gets up and says, we're going to have 1 million people living with HIV in the United States. In fact, I decided to take the job at CDC because of that talk that he gave on TV one night, because I knew he was wrong. But I thought if he had the guts to get up there and say this, I mean, we might have 1 million someday, right? I was sure we didn't have it then based on what I had seen, but he shocked the country, he shocked the agency. And I thought, this is the person I want to work for, this is the person that I can admire. And his heart's in the right place and his head's in the right place. So I got to work with him later. So CDC was shocked, and working on HIV in the early days, HIV did not have a focus. The only thing we had was in the surveillance unit, we had Jim Curran's operation, and they called themselves the Global AIDS Program at that time. And they were already doing international work. And so all the rest of them were like the Division of STDs. There was no separate HIV unit. The first one was formed with Steve Bowen and me in the office of the director. Dr. Alan Hinman was the director. And we were kind of, I think, the gadflies, the pests that everyone had to deal with during that time.
So this is the late 80s in the National Center for Prevention Services.
So we were not being mainstream. We were mainstream, so we were not given a real unit. It was only later that happened. The states, the first thing is that the states are overwhelmed by the amount of money we gave. And there's a whole story about how we got the money.
For the HIV prevention.
For the HIV prevention. They were overwhelmed. It had, in the first few years, more money than all the other programs. And we have what we called aid resentment syndrome. So all the other programs are upset because they had important public health needs. They were focused on this thing with AIDS. It's not that big just yet. Maybe it'll get big, but it's not that big. And why is it getting all the attention, the priority, and all the resources? And there's answers to that. And so we gave them so much money and they weren't sure about what to do. And we probably didn't give them very good guidance on how to organize. No, not probably. We didn't give them any guidance on how to organize. So. And we probably would have given the wrong guidance had we given it at that time. So they weren't spending their money. And money was being piled up in these states and cities all over the country. And the services were slow to emerge. And so one of my jobs was to push the states to get the money out there and the services up. And it was really about a 2-3 year period before we had, really thousands of sites and millions of people coming in for testing, counseling and testing under the model. It was quite remarkably stubborn and some states were much worse than others. California was kind of leading the group, but there weren't that many others that were moving that fast. And I remember in New York City that had not spent $3 million of its money. The Village Voice, a reporter at the Village Voice, got word of this and would call me up and say, is it true that they've not spent their money? And, I don't really want, at CDC, you got to tell the truth, but you don't want to get the health department in trouble. You're on the side trying to push them to get their programs going. And so it became very, very tight. And there was the Village Voice released a series of articles on this, kind of shaming the health department. And they ended up firing the AIDS coordinator in New York City, and they fired their financial manager as well. And then the new AIDS director invited me up and said, okay, now we're going to move. And that reporter, Mark Schoofs, is the guy that wrote he was promoted over the story, I think it was over the story, to the New York Times. And he wrote later on a series of articles on AIDS in Africa, which gave rise to was the impetus behind the support for the PEPFAR program later. So that was an interesting connection. So anyway, yeah, there was a lot of, and the idea of carryover. I remember Dr. Gary Noble would call me up about every few weeks and ask me, just explain to me what this carryover is. But it was the backlog of the money that we'd awarded early because if you get like $10 million one year and then you get $10 million the second year and you don't spend the first 10, then you got 20. And you only really have a program that's supposed to be running at 10 million, you get this bolus of money in the system, and you've got to do something about it. Eventually it'll expire. The grant will expire and you'll have to give it back to the Treasury. But in the epidemic where there's desperate need for services, we want to get this into service, not reimburse the Treasury at that moment. Didn't seem like a good idea. So
now you had a behavioral science background.
Right.
Were there others similarly at CDC? What was CDC's role in trying to improve uptake and get these programs going in terms of models of services for something very unusual like this?
Yeah. Well, we didn't really have, we had I had multiple degrees, and, after I got out of Vietnam, they told me I didn't need to take physical education because they thought I got a lot of exercise in Vietnam, so I got several degrees rather than just like the one major and minor. I got 2 majors, 3 minors, and I had, in these areas I had it. So at one time, Bill Darrow and I were supposed to be the social scientists at CDC, although Bill Darrow got his PhD. I never bothered to get the PhD in it. But that changed. We started getting, fairly soon, we started to get some behavioral scientists to come in, and so I had a chance to talk to someone who had more background.
Who were some of those?
Oh, let's see. I'm now aging out and my memory is going bad. I'll try to think of someone to tell you, but they're in my mind, but their name is hard for me to.
So there was a cadre of behavioral scientists.
There was a very small cadre. Well, Kevin O'Reilly was there, so there was the 2 of us.
Yeah.
And then there was. I'm sorry, I'm gonna have to go back, and I can send you something later to give you the names possibly. Sifki Rao was there, and I'm.
And were these folks working on ways to improve uptake?
Not so much, although they were there to advise us or help us.
Yeah.
But they were focused more on the intervention work.
Okay.
Because really, we still didn't have an intervention that we thought worked.
Maybe we should move to that. Let's talk a little bit about designing prevention programs. When treatment became available in the U.S. and certainly globally, but in the U.S., prevention took a way back seat, and we've almost forgotten about those days. But I think there were some important activities. Can you describe some of the approaches that were being used? We're talking late 80s, early 90s, before the big push with antiretroviral treatment in the U.S.
Right. So, well, the push, basically they were using motivations to help people think about becoming safer. So to try to find a way that would get them to focus on their risk behavior, think about the benefits of reducing it or the risks of not reducing it, and adopt a more safer lifestyle. But we didn't have, it's hard to go back and look because we didn't really know that much about this at that time. We had information from other places. Like in the STD program, they had the 8 motivations that you would tell patients. As a person coming with a background in behavioral and social science, I didn't think that 8 motivations were going to work because I was already more on the client-centered approach, even before we developed the counseling model. But basically, in these interventions, that's really how it was. Learn about the person's risk, learn about their living situation, their current situation, try to talk with them to go through this about how they could become safer and how they could sustain that over time. And so it was more of a dialogue with the patient. Now, early on, the AIDS, I forget, it was the AIDS Foundation in San Francisco came up with this kind of cognitive approach to where you would get them to declare in front of others that they were going to be safer. This is an approach used in alcohol. By the way, there's a huge amount of information about this in the area of drug abuse prevention, in which we were borrowing ideas from the drug abuse. People who had been counseling drug users for a long time had a lot of information about how to work with drug users. And that was coming into our system at this time. But the AIDS, I think it was the AIDS Foundation of San Francisco, had this and said that it worked. That if you just would declare among peers that I'm going to be safer or I'm not going to use drugs or whatever it is, there's a good chance you will become safer. The problem is they were doing that in San Francisco where a huge number of people had died. We also know that if you know someone who's died of HIV, you're much more likely to personalize the risk and become safer.
So the problem was that this wasn't representative of other groups. Where
from a methodological standpoint, you couldn't you have a distorting factor in there that's huge, maybe more powerful than your intervention. And
now,
then
I know you're focusing on men who have sex with men, but what about prevention efforts for the drug users?
Well, drug users, it sounds strange, but to get people to be safer from drug use is actually more successful than it is the sexual behavior. So you can get people to use a clean needle or to decontaminate or try to decontaminate the paraphernalia easier than you can get them to be safe sexually. The sexual behavior is the really hard one to and there's a lot. I forgot the national narcotics drugs. That was one of my projects for the Innovative, was the NDRL narcotics research in New York City.
Okay.
Don Desjardins.
Don Desjardins.
So I actually had him. They would advise us on stuff, and they had a number of interventions that had shown to work with drug users.
For example,
the role modeling, the role model stories. What was the other one that? I'm sorry, I'm blanking a little bit on some of it.
But what about safe needles?
Oh yeah, no, definitely safe needles. Cleaning, disinfecting needle. The first ones were needle exchange. First of all, clean your paraphernalia, your needles, the best you can, which we learned later, it's probably going to still be contaminated. The odds are dangerously high.
Okay. Using
a clean needle was the best intervention. I gave a talk at CDC to the big auditorium on needle exchange and the evidence behind it. And even in the early 90s, this research had been done in the late 80s, showed that this was an effective intervention.
So, but that was illegal.
It was made illegal by Congress.
So through the early 90s.
It was only illegal that the federal funds could not be used, but they could use private and state and local funds. And like in California, they did start some needle exchange programs. Okay. So that was the best one we had, to be honest with you. Methadone, another one of my projects was the intramethadone clinic, which the problem is that people are on long waiting lists for methadone. People wanted to get drug treatment, wanted to get off drugs, but they couldn't get access to the methadone or other drug treatment modalities. So we had this what they called the intramethadone clinic, which we would just give methadone to everyone on the waiting list, which some people thought that was a little bit heroic. Maybe that's a little too much, but it worked great.
Now, what about Congress and the?
Congress never heard about that one. Nancy Reagan visited the site when I was there one day. I locked myself in the bathroom so she wouldn't be able to find me and learn about it, although she had her guard come up and tell them, we knew you were there all along. So, but anyway, because we were afraid they would stop it. Mm-hmm. You know, and we had high hopes, and I, of course, had been on the team that had licensed methadone. And methadone works for some people. It works incredibly well in Vietnam, where I've been working. I don't think it works quite as well in this country, but it's still a good intervention. So you have needle, and if people stop injecting, then they lower their risk. Mm. So you can stop injecting. You can use a needle exchange. You can not share needles. And you can disinfect needles. It goes down in order of risk. So, and that works pretty well.
Now, but the federal government was not able to promote these interventions, is that right?
Well, we weren't able to fund them. I mean, we promoted them all the time. At least I did. But the evidence was out there in the scientific literature. It wasn't, I could just give someone a paper and they could read it. And that was much easier than the sexual behavior challenges.
From a behavioral point of view, but from a legal point of view, was there more difficulty from Congress and the administration on managing the drug abuse?
Yeah, well, they wouldn't support expanding treatment. They said that you cannot promote drug abuse, which some of these things they thought of as promotion. They specifically outlawed needle exchange for the use of federal funds. They were very negative on this. They would harass us. You know, if we had a conference on harm reduction, we couldn't talk about harm reduction. If we had a conference that had the title of harm reduction, we'd have congressmen calling down to CDC to stop it. And this was, you know, not good.
So, in terms of the prevention programs, these were also cooperative agreements with state and local health departments.
We folded this all into one, we called them the prevention cooperative agreements. I think in the second or third year that we awarded them, we started folding them because they all reinforced each other.
That and the counseling and testing sites?
Yeah. Yeah.
Okay.
And by the way, just back to how do we know the intervention? For the sexual behavior interventions, the problem was we were kind of trapped by the system that we had. So we had the counseling and testing, and we'd kind of expanded the counseling and testing to be as effective as possible under those circumstances. But in terms of longer-term behavior change, the percentage that changed, reduced their risk, and sustained lower risk was low. And it was more likely to be the people infected. And there was one study, many studies I read that would find that about a third of the people made serious changes and appeared to sustain them. But that means 2/3 didn't. 2/3 of the positives didn't. So then people tried to think of, you know, other interventions. The problem is that if in your life, if someone come and talk to you for 30 minutes or an hour, you're probably not going to change your life over that. And I think that behind everyone, it's kind of like I used to say, it's the magic message. If I just say it a different way, maybe they'll do it. But the reality is it just didn't have that much impact on people's lives. You had to change the whole environment. You had to do many more like Kevin O'Reilly's group was trying to do with the community-wide change. I think that would reinforce individual behavior change. So
around this time, a couple of things were happening, quite a few. First of all, you're getting pressure from ACT UP, the AIDS Coalition, to unleash.
Oh, we kind of liked ACT UP, though.
Yeah.
Because they were
how did they help in terms of?
They started, you know, they harassed CDC staff. So I think Dr. Noble was tied up in the chair one time. Jim Curran can tell you all about things that they did. They had targets with him and his face in them. But they drew attention. They drew attention to the issue. And basically, we wanted attention drawn to the issue. We couldn't get up and say, silence equals death. We wanted to, because it's the truth. But they could. And they got up. And they weren't friends of CDC, although they'd softened up in later years. But they got attention. They connected with people in Congress that CDC couldn't connect with, They got support, and we got money. In fact, there was an IG, Inspector General investigation about how we got the money, for the program. And they came down and interviewed me, and I said, well, I don't know. We just write a proposal, and somehow it magically shows up in Congress, and they give us the money over the heads of the directors of CDC. I don't know, I really can't explain that whole process to you, but it seems to work pretty well. So Steve Bowen and I wrote a proposal one time, but what if there was a treatment? And sent it up to Dr. Mason, and we got I forget, you could look it up, but maybe $200 million we got, something like that. And we would have gotten more, but Dr. Mason wanted the states to pay for the rest. Mm. So we had this whole kind of side business of working with our friends in the activist community. We got really knowledgeable about that.
Now, there was also Surgeon General Koop.
Right.
Sent, sort of defying the politics of the time.
That's right.
Developed an important mailing to every household in the United States about AIDS.
Well, he didn't develop it, we did.
Okay, tell us more.
Yeah. Well, Koop was a great leader in my mind. He wrote the monograph on condom use, which was, I answered hundreds of letters from people who were mad about Dr. Koop doing that. But yeah, one day, I forget how this story, Dr. Koop's name got put on it, but congressmen wanted to do something. And this idea that we would mail a letter to everyone in one congressman's jurisdiction or everyone in the United States started getting, support. And we were always very skeptical that, how many people would not read the letter? Maybe half the letters would be unread. What would you say in the letter that they don't already know through the massive news coverage we've already received? I mean, Jim Kernke could get on any TV station and give the same information out to all the news outlets. So it seemed like the value of a letter was marginal. But I actually don't remember exactly how it is that we got the mandate that a letter's got to go. And then it was assigned out to a consulting organization. The CDC staff didn't work on the letter and weren't allowed to review it. And so there was an uproar. We had a weekly meeting on AIDS. I took the notes for years on I don't have those notes anymore, but that would be an unbelievable history of all the things that happened. But they wouldn't let us come and see the letter. So finally there was an uproar among the senior staff of CDC saying that we're not going to stand for this. You're going to have to show us the letter. And so the contractor made us come here to Clifton Road at 8 o'clock in the morning on a Saturday morning. And there was about 10 of us that were there. And they showed us the letter. And of course, it was horrible. It was totally horrible. And so we rewrote the letter. We knew we didn't have the ability to not send a letter. That CDC had been mandated, but we at least would try to send a reasonable letter, a factual letter. And
do you remember what the essence of that letter was?
Well, the original letter, the
improved letter.
The improved letter was to inform the public about the true risks of HIV and what they could do to protect themselves and their families. Mm-hmm. I was the one that said that every parent ought to talk with their children about this. I wrote that into the. We were doing this just in a very short time period, because they'd held the contractor had held the letter so long. And they had Tony Fauci, and they had juxtaposition people living with HIV. So you think it was Tony Fauci was the person living with HIV, and but the letter was much better. Now, whether it had any impact, I really doubt it. But there's a letter. Everyone signed a letter, and somewhere around here, someone's got a copy of the original letter with all the signatures on it. Mm-hmm. But
so I think maybe that had an impact in terms of the morale of some leadership. I guess the other things that were going on were people like Rock Hudson and others dying of AIDS. And so CDC began the program America Responds to AIDS around that time.
Yeah, America Responds to AIDS was part of the letter. That was one of the things that they did.
Okay.
Yeah, we had a business response to AIDS. And,
So did your prevention grants dovetail with those
We tried
efforts?
to. We tried to, although they were much more controlled by the Department of Health and Human Services than we were. And so everything they developed had to go up and be reviewed at high levels. It's hard to, so they had trouble becoming explicit. Like they had one where put your socks on. They told the world that everyone put their socks on, which was meant to be put condoms on. But most of the world thought it was put your socks on. They had a balloon one with a lot of balloons, like This Is a Wonderful World thing. In fact, they played This Is a Wonderful World in the background. And most of the time, people couldn't understand, we couldn't understand what the AIDS message was in a lot of these.
Okay.
But I'm not trying to criticize them because Ogilvy and Mather was, that they weren't allowed to be specific because they would have the overseers, knocking it out when they tried to. And they had one about people who were going to be monogamous, and they were not married yet, but they loved each other, and they were talked about how they'd be faithful. It was deemed as too sexy, and that was stopped. I actually thought that was a good one, but they stopped that. So anyway.
Other things that you worked on, you mentioned before the community-based cooperative agreements.
Right. Community planning.
Can you tell us a little bit about that in terms of your role at that time? And I guess here we're talking about the 90s a little bit more.
Early 90s, yeah. Well, we had this chronic problem with the states being slow in response. Most of the states being slow in response. They had improved somewhat. They were spending a greater proportion of their money. Services were out there, but they were still slow. And they didn't have strong relationships with their communities, the gay community, the minority communities, maybe not with any community. They just weren't, they were kind of islands. Many of them were just really islands in the state. They weren't connected well to the communities at all. And yet we're trying to be organized and mobilized communities, be community focused in our interventions, and so we had this big gap. So how do you bring these health departments and the communities together? And so we had a retreat, and Harold Jaffe and Jim Curran and Ron Valdesari and a lot of other people were there. Jim Buehler were there at this retreat, and the consultant of the retreat tried to do World War II analogies. So he got up and talked about World War II, and we're all sitting there thinking, look, we're fighting a different war. We're past World War II. We don't have any tanks, So Jim Curran fired him in the middle of the meeting, fired him. And he's put him in the corner, and we just talked. So on the second day of that, they put up a number of questions. And on the second day, I came up with this concept called community planning, where the communities would have to sign off on the grants. So they would have to form a community panel that's representative, and they would have to meet and talk with the health department about what needs to be done, what interventions, what services, and that they had to get the signatures of the leaders of the panel. And the leaders of the panel could disagree. They could say, I'm signing this, but I don't agree with the health department's application, or they could agree with it. And if they didn't agree, then CDC would just look into what the areas of disagreement were. So there couldn't be like an arbitrary reason to hold back the health department. And we implemented it. And
how did that work? I think later there actually were funds sent right to these community-based organizations.
We also started a separate program where we separately funded the NGOs, the local community organizations. But the way it worked is we just forced it on them. So I got up at a big meeting of all the states, which I got used to doing at that time, and I said, you've got 1 year, this is the program. And went over. We'd consulted with them. They had input into this. But I had all the states together, and I said, you've got 1 year to implement this. We're giving you extra money to do it and so forth. And that year's only 9 months long. So that's, and they still remember this, a lot of them. And they did it. And we also had decided to co-opt the states by working with this group called the National Association of State and Territorial AIDS Directors. And we had actually supported them. They were our antagonists at the start, but then we realized, well, we might as well, we're in this together, whether they think so or not. So we started working more directly with them. And they were really helpful in all this, and they supported a lot of the programs. They criticized us a lot too, but they they supported the most important initiatives that CDC was trying to do.
So I remember it was kind of a struggling transition to move direct funding from the state and local health departments, where presumably the expertise resided in these
Right.
interventions,
To the community-based
community-based organizations.
Yeah, there was absolute resistance to it.
Where, what's your thinking about it now that you have the luxury of all this hindsight?
Well,
Did
money
we-
wasn't getting to the community-based organizations. That's just the problem.
So when you moved the money to the community-based organizations, did the quality suffer? How did that work?
Well, you have to think of it in different iterations, just like the counseling and testing program. So the observation is that we need the community organizations that are doing all these services for the people living with HIV and people at risk. That's where they're doing much more service than the health department, which is mainly doing the counseling and testing program, you know.
So by now the service includes the beginning of treatment.
We're getting into treatment, but we're still really treatment for opportunistic infections. We really aren't yet into the antiretrovirals.
Okay.
We're setting the stage, though, because we had in our minds that there would be a treatment coming, and that we wanted to have the system set up. And I used to talk to some of the leaders that we want to have a system set up so that we can rapidly diffuse the new treatments or whatever tools we have into the community as fast as we can and as effectively as we can. So we need to have that infrastructure in place. But we found that the health departments were not sharing the money or sharing it very slowly and having kind of, really poor oversight over the communities that did get money. So, but we had all these organizations clamoring to get money. So we decided just to start giving money directly to them. And Sue Dietz and I sat down and wrote the program announcement for this and designed the whole program and just defined what a community-based organization actually is, which was, I don't think it had ever been done before, at least I don't know about it, and started funding them. And the first group were pretty bad, because they had the same problem. They had a lot of people that wanted to do good things, but they didn't have any interventions that were going to make a difference.
Did they have the skills to
Not really.
implement?
But very few people or organizations did at that time. You have to get started before people can get trained and experienced and start training others and expanding the skill set out. So if you're starting at the base level, you want to make sure you're getting to the community. So the definition of the community
would they have been community health settings?
They could have been. They could have been a community.
Were they churches? Were they storefronts? What were these community-based organizations?
Some of them were newly formed. They had to either prove that they were representing the community in some way, like that they had some kind of representative function before we funded them, or that they had been serving the community with an important service. Could be a community health center, for example. And there was a third one. I'm forgetting what it is right now. But there was four criteria that we used. So we knew we were getting to communities that if they had the right intervention, they could serve the community.
Okay.
So now the issue, if we fund them, now the issue is get them the right intervention, because maybe their service is good, even the way it is, but it's not going to help us reach the ultimate goal that we need. They need better interventions. But we can now have a conduit to the CDC technical expertise, and also if there was some from the state or local health departments, they could get it there. So we set up the system so that it could grow and become better over time.
You think it was successful?
I think it was successful, although the first group, when we went to the second iteration, almost all of them lost their funding because our new cadre of organizations that were much more capable figured this out.
Like what? Like what types of organizations?
Well, they were still kind of the same types, but they were more experienced, had a better idea of the intervention, and about 80% of them lost their of the original ones lost their funding. And I remember going to Dr. Sencer and telling him that what was happening.
Director of CDC
at that time. And he said, well, you have to do what you have to do. And then the Clinton administration called me up and told me to change it. And I said, well, we can't by the they were trying to do good things, but by the grant rules, we can't change it. It's, they've lost. Others have to win. They can reapply another time.
Okay. Well, I don't want to end your interview without getting a chance to hear a little bit about your international work, even though it came a little bit later.
Sure.
You had so many important experiences. So in the 90s and 2000s, you were expanding these programs internationally, and you eventually worked with PEPFAR. And I know you were intensively involved with Vietnam. Do you want to talk a little bit
Sure.
about some of those activities?
Yeah. Well, let me tell you how it started. The International AIDS Conference in British Columbia, I think in 1994, I think. May have my year wrong. I was walking down the corridors at the conference center, and I walked past the Vietnam delegation. And, I'd been in Vietnam, and I had run the CDC Indo-Chinese refugee treatment program, medical screening program back in the early 80s. And so I stopped them in the hallway and tried to talk to them, but they didn't speak any English. So later I saw them in the lunchroom. So I saw them again and sat down and tried to talk to them, and I tried to say, is there a way we can work together? I'd already done quite a bit of international work, so maybe something can go here. And they weren't sure exactly what to do, but I then told Helene Gale about this, who also approached them. And then next thing you know,
And Helene was...
it must have been 2005. She was the director of the HIV center at that time.
Yeah.
And I think it must have been 1995 that this actually happened. And then in January of 1997, we went to Vietnam with Helene. I think that's the one you were on. So, and we talked with them about setting up a collaboration, and they were all for it. Then I went back to the U.S. and with the team, but then I went back several other times after that. Then I wrote a plan for helping Vietnam with HIV and other public health issues, and then got appointed to be the first director in Vietnam, and opened up the CDC office in Hanoi, and a lot of things came.
Did you live there at the time?
I lived there, yeah, with my family. I was the first American advisor to the government, outside of military and diplomatic. I was the first American advisor to Vietnam since the war. So we lived there 2-3 years. We came back. No, I was there about 6 months. And then I came back to talk to my family. They hadn't moved there yet. They did move later. And Helene tells me that she thinks we have a chance for an international AIDS program. So on my home computer, I wrote a proposal for an international AIDS program, turned it into a committee that was working with Helene on that, and they made some edits, and that turned in and got $48 million from the emergency fund for a global AIDS program. And this is because, underscored was this Mark Schiff's article series on AIDS in Africa. And then that later we got to 105 million dollars expanded in the second year, and that became the global AIDS program. A few years after that, I wrote a speech for President Bush to go to the G8, I think is in Canada. And you write a speech for the president, the speech writers, you never know what he actually said, if he used any of your speech or not, but apparently he did use it. So he came back and he said that he wanted to do some of these things. He liked it. So we wrote a proposal, R.J. Simons and I wrote a proposal first for counseling and testing in Africa, and to prevent vertical transmission of HIV. And out of that came a $500 million program called Save a Generation of Children in Africa. And then later, the same group got together, but with Tony Fauci's, Mark Dybul, and we wrote a proposal, and that became PEPFAR in 2003. So anyway, that's probably the biggest event in my international work. And then I came back a few years later and became, for FHI, became the director of programs and research in Vietnam. But I also had a chance to work with the Chinese, with the Indians, with a number of the African countries, and advise them especially on counseling and testing. And they were like me when I was back in the early days trying to figure out what you're going to do with this program. So they related to me very well, because public health people with the same challenge, but one's actually been through it. There's a bond there. And so I was able to help them structure their programs, both in Vietnam, China, India, the ones that stand out to me at this point. I don't know. I think their programs might be better than ours. I don't know. I doubt it. But But
There was a lot of controversy, I know, in Africa about the duration of counseling and when to make counseling and testing actually an opt-out approach once
Right.
medications became available.
well,
What was your experience with that aspect? That was
Yeah.
over time and a change in availability of
well,
drugs.
part of that was because of we needed different counseling models for places where more extended counseling was not feasible. And another thing was that the client-centered counseling, one of the fallacies of it was that it was too complicated to use it really widely. That's true of a lot of interventions. They can be too many sessions or too expensive, but they can also be too complicated that people don't really grasp the essence of what it is, what we're trying to do, and they do it by rote. Just give the facts, or, you know. So we found that it never really permeated as much as we had hoped, although it permeated substantially, but not as much. But it did make it more lengthy. Mm-hmm. So I used to talk to people who were trying to shorten it. I said, if you are talking to a client and the client doesn't have any risks, or remember the counseling is based on their circumstances. So maybe they don't need any counseling or don't want any counseling, and they don't need it. That is the model. The model's not spend 45 minutes telling them something they don't want to know. You got the wrong message. The message is if they're a drug user, they need to know information about drug use and how to prevent it, or if there's a gay man, whatever might be suitable for or appropriate to their needs. It's not to lecture them or to, but we had this chronic problem, and that's a fallacy. So I talked at length with a lot of the CDC staff that were trying to shorten it, but on the other hand, and Don Francis, who worked with us early on, he set up these prevention treatment centers in California, and we funded it in the early days, and we didn't have any treatment, so that was definitely the cruel hoax. We had opportunistic infections, but he told me in the end we had to end them, and he wanted to end them. But the problem was that the people came in had so many problems that you couldn't. And these centers couldn't address all those. It was just hopelessly expensive and time-consuming. And so you have to run this. You're working with a population where many people have many needs. And to help them, you have to help work them through some of those needs, at least enough to make so they can become safer. But you can't address all their needs, but yet they're with you. So I also wonder when people talk about they're only going to do the short counseling, when the patient says, I need this or I need that, are they just going to send them away? But I definitely see the issue. So like I say, the program is growing and getting better and being refined over time. And now I would say the basic thing is to get them on treatment. This treatment is so effective, and we did the study that more than 90% of the protective benefits, more than 90%. You have 90% or greater prevention of transmission within a discordant couple. We don't have any counseling model that comes close to that.
Right.
So just get them into counseling. Just get them into treatment. Just treat them.
The world
Yeah.
changed.
So the world changed with that study, and I told the people in Vietnam, it's a total sea change, and I'll tell the organization I'm going to do the talk for later this month or next month that changed everything. And so,
looking at, you had really a leadership role in so many of these aspects. Can you reflect a little bit on CDC's leadership? What do you think were the strengths? What might have been some of the weaknesses or things we could have done better as you look over the whole course?
I think that CDC was a true leader. I mean, it was standing up when no one else was there and fighting an epidemic. And I think I mentioned before that, if you're facing a really brutal epidemic, and it's occurring mostly among marginalized groups that don't have a lot of political power and are discriminated against, that's a tough program to take on. And even when you get a lot of money, there's still a lot of issues. And CDC really stepped up and worked on it and gave us an opportunity to experiment, to develop and grow the program, make it better over time. And there were thousands of battles, over this. It could have been faster, but again, it's easier to look back and see that, for example, the epidemic, as I understood my friends who work in surveillance, had not progressed as much in the 80s as they thought it had. You know, when Jim Curran said there's 1 million Americans, it was probably much less than that, in fact, at that time. And it did get into a period of exponential growth, and there's an epi curve for the U.S. that shows the curve. So maybe we had a chance early on with a true national mobilization that we could have really changed the course of the epidemic. But we didn't have the tools, we didn't have the knowledge, we certainly didn't have the political support. I don't think that was really possible for CDC to, I mean, even if it knew it could do things, I don't think it could have pulled it off in that time. We had trouble enough, as I've described already. But through the years, they've been a leader of this and in many other programs, and they're highly respected around the world. I mean, the Vietnamese, many of the Vietnamese I work with, you know, they were in the North Vietnamese Army, or they were Viet Cong. You know, they fought the Americans, and I was at a party with them one night, and many were getting drunk and so forth. And they said, you know, during the war, we followed the MMWR. So that's pretty good political capital, right? There's a reason that they followed it, because they saw it as a voice of reason, a voice of science, you know.
That's a great line.
So anyway.
Well, thank you very much.
Thank you very much.